So the problem is there everywhere. We love our patients, especially patients with chronic diseases. We take care of them, and we are always very attached to them and delay until the last moment to let them go. So transition is absolutely needed, and a definition is that it is a change or shift from one state to another, and it should be a progressive process. When a young person, an adolescent, breaks a leg, has acute disease, well, they are really limited in their activity, but they know that within a few months they will be okay and they'll resume their normal activity. However, patients with chronic disease, they may have some physical limitations, but they know that will stay for a long time, and they may not have exactly the same type of activities or life that their peers do. So they are more affected in their conditions. So the advantages of the pediatric care is that we understand that this adolescent process leads to independence, helps them to be autonomous, to be in full responsibility for their disease. We listen to their opinion and we respect those points of view. However, when they change to the adult clinic, they have to sort out their problems on their own. I mean, the doctor tells them, you have this investigation, go and do it. And they have to look ways to sort them out. They become fully responsible for the decisions they make, to follow or not the recommendations. They sometimes feel they are being abandoned because parents are not in charge anymore. The doctor just gives them the prescription and tells them to go away. So they tend to feel quite insecure. And also in gastroenterology, they need sometimes follow-up endoscopies. And in some adult clinics, to provide full anesthesia for all procedures is quite a limited resource. So there is a dramatic change, and they have to face that, and this brings problems. It has been shown in several diseases that if a transition process is not properly organized, the dropout and the abandon of clinics is quite high, and that affects the prognosis of the basic condition. So if we take several examples of chronic diseases, digestive diseases like celiac disease, well, the problem is that they need to comply with the diet every time and everywhere they go. Sometimes they feel embarrassed because they are refusing to take some measures or some foods in front of their friends, and they need to comply with that. In IBD is a special problem because this disease, if not properly treated, it relapses and it may not respond appropriately to the same medication. So there is a real risk if they stop medication. And sometimes the medication they are taking loses effect, so they need to change to different treatments. So IBD always creates a bit of a problem. I tend to tell our adult colleagues that our patients with IBD are a bit of a time bomb because they may be reasonably controlled, but sometimes they have already gone the various therapeutic steps, and when we pass them to the adults, there are less options left to be taken. So we have to prepare this carefully. Another condition is eosinophilic esophagitis, because we know that we can control symptoms reasonably well. However, sometimes endoscopic or histologic remission is not complete, and although patients feel well, they have a risk of stenosis later in life. Therefore, compliance with treatment is also very important. Of course, they need repeated endoscopies, and again, sedation is a problem. Patients with intestinal insufficiency, with short bowel syndrome, they depend very much on chronic and heavy treatment, on parenteral nutrition and home care. So it is very important that this process is properly handed over to the adult colleagues. Well, being treated by a pediatrician has a lot of advantages to our patients. So we look at the patient in the family, we ask the parents how they feel about it, and we discuss with the whole family about the evolution and how to manage the disease. It is a pediatric environment. They are reasonably protected from various aggressions, so to say, in the hospital environment, and we tend to create a special milieu for them to be to see their doctors. And everything is organized in order to take care of the child. We pay specific attention to growth and development. It's not only about treating the disease, but also to make sure that they grow appropriately, because you cannot grow at 30 years of age if you did not grow at 15. Well, however, we as pediatricians make silly mistakes. We allow our patients to be sometimes quite quiet in the consultation. We discuss with the families, and we condescend with poor compliance from the patients. We always discuss the situation with the parents. So the child, if he is very passive, is very quiet, and the family takes care of everything. And one day, when we pass these patients to the adults, then it's a dramatic change in their lives. So we have to be aware of this risk and start early, before transition, years before transition, to empower the child and the adolescent, and to make them responsible for taking the treatment, for doing the investigations and everything. So this process is a slow evolving process, and it matures at one point, but we have to start early. So there are various barriers which may make transition a bit difficult. The adolescent behavior, we know that adolescents are not always the same, but sometimes they are quite rebels, and they tend to resist to our interventions, and they may be, some of them, quite apathic, some very resilient. So we have to be aware of that, and we have to address each one separately, especially if they do not adhere to the therapeutic measures. Well, we have to take care of the developmental changes as a result of chronic disease. Some of them with chronic diseases, and again, IBD is one example, they feel they are very diminished in their lives. Quite often, I tell them when they are diagnosed, and once they are controlled, I tell them and the parents to go into internet and look for public figures with IBD. And they will find presidents, politicians, journalists, sportsmen, artists that live happily with their disease. So they have to understand that they cannot get rid of the disease, but they can still lead a normal life. So we also need parents to be involved, but parents have to slowly let go and empower their children for the next phase as adults. Some barriers that also bring some difficulty are the lack of training of pediatricians. Sometimes we forget to take these actions well in time in order to prepare the transition. And sometimes we do not communicate properly with the patients or the parents. So it is really important that we are fully aware of this during our clinics, and at 15 or 16 we direct our conversation to the patient directly in order to empower them and to let them speak and listen to them. So this is important. Our adult colleagues have quite a different approach, and we must also discuss with our colleagues, and we should select an adult gastroenterologist, expert in IBD or celiac or eosinophilic or whatever, so that we agree on common protocols and they are prepared to take over our patients in a smooth way. So our adult colleagues sometimes are inexperienced in handling these patients, and we must prepare them in advance. Some systematic barriers are the lack of a transition program. So each department or each unit should organize a well-planned transition program so that everything is set up well in time so that the process moves slowly and smoothly. Sometimes funding is an issue because if we have joint clinics, there may be an issue who bills the insurance or the health plan and who gets the money. So everything should be well planned in this regard. And we should have a written protocol so that everyone knows exactly what is expected to do. And a coordinator in each program should be appointed in order to make sure that all the steps are properly prepared and planned so that everything goes according to the plan. And this coordinator should monitor the process and should tell the doctor, well, this one is ready for the next phase, but this one is still immature, and we should probably delay a little further this situation. So this coordinator should support the adolescent through the process. And the appointments should be scheduled according to the specific needs of each patient, and communication should be very open so that we monitor and we make sure that every phase is well filled. So this is a flow chart where you see that the process should start early, and then throughout the various age groups we should introduce the various features which are responsibility of the patient but also the parents. The coordinator of the transition process should monitor the whole phase. The pediatric GI doctor should slowly fade away while engaging the adult doctor progressively so that both coordinate their approach and the transition is quite smooth. I have had, and certainly all of us have had experiences when we hand over a patient to the adult doctor and sometimes later they come back to us and say, "Doctor, I need your advice because the other doctor, he doesn't care for me." So we must choose, again, someone who is wise and ready to understand this process. So it is a bit like this prayer of a child. We want the bad guys to be good, but we also want the good guys to be nice. So having someone who's empathic to take over the care of the patient is really very important. So we should look around and choose the right adult physician. We may not have the same person for all various diseases. Adult physicians are also specialized in various areas and we should respect that. If possible, we should have someone in the same institution. It's much easier to coordinate rather than having two separate institutions far away from each other, but that depends on local capacities. We should agree on common treatment protocols. I think this is quite important. It is very puzzling for a patient. Again, I will take IBD as an example. If I'm having a patient on biologic plus azathioprine, and then he goes to the adult doctor and he says, "Stop azathioprine, that doesn't do anything." Well, it just creates messy confusion. So we have to discuss with our adult colleagues common protocols. And even if they do not agree entirely with us, they should change slowly the protocols and not make an abrupt change that confuses the patient. And of course, we need to find a colleague who's sympathetic to the crisis. We always have scheduled appointments, but we should be open to see the patient earlier than planned if there is something going wrong. It is not as easy to do this with adult colleagues. So we should try to identify someone who's ready to listen to them, to anticipate an appointment to discuss specific issues that they may wish to bring up. So, pediatric patients have increased problems. They have quite often more severe disease. Early onset diseases often have a more severe prognosis because there is probably an increased genetic factor into the emergence of the disease. So these tend to be worse patients. Also, as I mentioned, quite often they have already undergone various treatments or even surgery. So these are more difficult patients to manage later in life. Quite often they have had various medications. The anxiety is not only with the patient, it's with the patient, the parents, but also with us, because we let them go and we always feel a bit sorry for losing those patients, and we should be prepared to manage this anxiety jointly. And of course, the attitude of the parents is really very important. If the parents are too much in control every time, then the child will always be a child, and suddenly they will feel abandoned. So teaching parents how to behave and how to respect the adolescents and how to empower them is always really very, very important. There are various models of transition. We may write up a report, a letter, and give it to the patient and go and see the adult doctor. Well, we may have some overlapping in functions and have joint appointments, and where we introduce the adult doctor, we explain the situation, the plan, and then let them go. Or we may have a model where we gradually are becoming less prominent in the process and let the adult doctor progressively to be more in charge of the process. So this transition is smoother. Clearly, this model, the last one, is more advantageous, but it depends on the personality and on the local facilities and the capacity to have various joint appointments. So we need to choose the right time for each patient. We should transfer the patient in a moment where his disease is stable. It is difficult to send a patient who is on a relapse from IBD or from eosinophilic esophagitis, so we should perhaps sometimes transfer them not at 18, sometimes at 19 or 20, but to allow the situation to be fully controlled and in remission, so that transition is smoother and don't need to make jumpy changes in medication, and plan the joint appointments. Keep the channels open, so allow the patients to come back to express their concerns so that we listen to them, and we may later discuss the situation with the adult colleagues, and keep an eye on quality of life. That's a very important factor that is being more and more discussed in every disease. So we want our patients to be biochemically normal, but we also want them to be happy and to have a normal quality of life. So this is really an important. And of course, we have to prepare detailed reports to hand over to our adult colleagues. Well, all doctors caring for these patients should be aware of the transition process. They should have competence to facilitate this process. And of course, they need to be informed about the timing to hand over the patients. And this is where the coordinator of the process is really important to help us to make decisions. So altogether, we want our patients to cross this bridge, and rather than seeing nothing on the other end, they can see a nice future for their disease and their lives. Thank you very much.